Hey Yumna, welcome. I'm your virtual exam coach, and today we're diving into an intense, high-yield study explainer designed to help you completely crush your PHAR 13672 Nursing Pharmacology Final. Look, pharmacology is notoriously tough, mostly because of the sheer volume of rote memorization it demands. But today, we're the antidote to all that overwhelm. We're going to completely bypass the fluff and focus entirely on the clinical reasoning, the priority actions, and the memory cues you actually need to win.
So here's our 5-step blueprint for this explainer. 1. The exam blueprint. 2. Core foundations. 3. Endocrine and diabetes. 4. Cardiovascular drugs. And 5. Rapid-fire mnemonics. Let's get into it.
Part 1. The exam blueprint.
All right, so you're going to face exactly 65 multiple-choice questions, and you've got a 2-hour limit. To put that into perspective, you have just under 2 minutes per question. Now, while you are responsible for units 1 through 11, you really need to heavily prioritize units 9 through 11. Those later units, that's where they're going to pull the bulk of your critical thinking and application scenarios. Mastering these priorities is absolutely your ultimate time-saving strategy when you're sitting there deciding what you, as the nurse, should do first.
Moving right along to Part 2, Core Foundations.
Okay, so these ADME steps, absorption, distribution, metabolism, and excretion, they dictate a drug's half-life in the body. Just remember that drugs with short half-lives require more frequent dosing to maintain those therapeutic levels. But here's a massive real-world warning for you. Any renal or hepatic impairment in your patient will dangerously delay that final excretion step. Seriously, ignoring a patient's liver enzymes or creatinine levels before giving a standard drug dose is a classic way to fail an application-level exam question.
Let's do a quick active recall pause right now to kind of mimic your real exam environment. How does aging specifically alter this excretion process we just talked about? Take a second and think about it.
Got it? So the big takeaway here is that older adults literally have fewer intact nephrons in their kidneys. This drastically slows down drug clearance, and it severely increases the risk of dangerous drug accumulation and toxicity. Imagine you're assigned an 85-year-old patient. You have to assume their clearance is compromised, even if their routine lab work looks, borderline normal. Keep this physiological change top of mind for literally any geriatric case studies you see on the final.
All right, Part 3. Endocrine and diabetes. Let's get some points here.
Listen, when you're administering insulin, site selection is absolutely everything. Just remember that the abdomen provides the absolute fastest absorption rate, while the thigh absorbs much more slowly. Think of it like this. If your patient's meal tray just arrived and their blood sugar is spiking, you need that rapid abdominal absorption to act immediately. But if you're giving a baseline, long-acting dose to sustain them overnight, that slower thigh absorption might be a much safer bet to prevent a dangerous crash. Okay, let's lock in these essential rules for metformin. First, metformin meets meals. Giving it with food significantly reduces GI upset, like nausea and diarrhea. Also, keep in mind, it doesn't cause weight gain. But more importantly, kidneys clear metformin. This means you've got to rigorously monitor serum creatinine because renal impairment is a strict contraindication here. Imagine your diabetic patient is scheduled for a CT scan tomorrow. You've got to immediately remember, contrast means hold. You always hold metformin for tests involving contrast dye to protect those kidneys.
Now check this out. Steroids send sugar up. This brilliantly illustrates a really common exam trap involving a totally different drug class. And let me tell you, nursing professors love testing this. Corticosteroids actually antagonize the hypoglycemic effects of insulin by forcing blood glucose levels to aggressively rise. So if you've got a well-controlled diabetic patient who is suddenly prescribed a steroid for an exacerbation, you have to anticipate, monitor, and potentially treat a massive spike in their blood sugar. Do not let them trick you with this on the final.
Okay, deep breath. Part 4, Cardiovascular Drugs. For this section, you've got to be able to instantly contrast these key cardiovascular classes, and more importantly, understand the specific dangers of their side effects. Take metoprolol, right? It's a beta blocker. It drops heart rate and blood pressure. But the hidden danger is that it masks the signs of hypoglycemia. This is deadly because a diabetic patient won't feel the crucial warning signs like tachycardia or tremors before passing out. Compare that against hydrochlorothiazide, which causes dangerous potassium loss, leading to cardiac arrhythmias. And then contrast both of those with captopril, an ACE inhibitor, which is notorious for causing dangerous first-dose hypotension and that persistent, dry, non-productive cough. So zooming in on those beta blockers for a second, the crucial clinical priority here is that beta blockers block the beat. Before you even think about pushing that pill, you are putting your stethoscope directly on their chest for a full 60 seconds to check that apical pulse. You absolutely hold the medication and notify the provider if it drops below 60 beats per minute, unless, of course, other parameters were specifically prescribed by the physician.
And for ACE inhibitors, I need you to sear this memory phrase into your brain. ACE equals angioedema, cough, and elevated potassium. Understanding the clinical priority here is exactly what your nursing finals will test. Look, the dry cough is annoying, sure, and it's super common, but the angioedema, that rapid swelling of the face, lips, or throat, that is an immediate life-threatening airway emergency that must be reported the exact second you see it.
Let's bring it home with Part 5, Rapid-Fire Mnemonics.
Time for another rapid flashcard pause, and this one requires absolute urgency. You have an oncology patient with a dangerously low white blood cell count due to severe bone marrow suppression. What single clinical finding requires an immediate drop-everything call to the prescriber?
It's fever. Fever is an absolute critical emergency in neutropenia because these patients just don't have the white blood cells needed to mount a normal, robust immune response. A fever is often their only early sign of a rapidly progressing, life-threatening infection. Even a low-grade temp of 104 degrees Fahrenheit, that's 38 degrees Celsius in this patient, is a flashing red siren. Never ignore it. Notify the physician immediately.
Okay, if you see Parkinson's disease on the exam, this classic phrase tells you exactly how the Sinemet combination drug works together synergistically. Levodopa gets dopamine into the brain, carbidopa protects the ride. Basically, levodopa converts to dopamine in the central nervous system, but it desperately needs carbidopa to prevent its peripheral destruction. Without carbidopa acting as a shield, the levodopa would cause massive peripheral side effects, like severe nausea and cardiovascular issues, way before it ever reached the brain intact to do its job.
Laxatives. If you get a matching question on laxatives, honestly, do not panic. Just walk through this simple physiological sequence. Think of it like a sequenced rescue mission for the gut. First, you create the bulk with a bulk-forming laxative like psyllium. Then, you provide the moisture to soften things up with an emollient like Docusate. After that, you actively draw water into the intestines with a hyperosmotic like polyethylene glycol. And finally, you give the intestines the push they need to clear it out by stimulating peristalsis with a stimulant like Senna. Easy, right?
Also, never, ever confuse your asthma interventions. Salbutamol, that's your rapid, acute rescue inhaler meant to open airways instantly. Montelukast, on the other hand, is a leukotriene receptor antagonist. It reduces airway inflammation over time, meaning it's strictly for long-term prophylaxis and is taken continuously every night. The real-world consequence here is huge. Handing a patient a Montelukast pill during an acute asthma attack instead of their salbutamol inhaler could literally be fatal. Always know which is your rescue and which is your maintenance.
So, Yumna, you've now got the precise study explainer you need to completely sidestep those exam traps. You know exactly when to hold a beta blocker, why you absolutely have to check a neutropenic patient's temperature, and how to manage and protect kidneys with metformin. The only question left is, when you sit down for that exam and all the multiple choice options actually look correct, which airway, breathing, or circulation priority will you actively choose to save your patient first? Trust your reasoning, Yumna. You've got this. Go conquer that final.